Hello, my name's Sarah Hammond. I'm a member of the Division of Infectious Diseases at Brigham and Women's Hospital, and I'm an assistant professor at Harvard Medical School. I'm going to be talking today about clinical pearls and infectious diseases. So first, my disclosures. I have research funding from Merck and iCuris. So I'm going to give you a quick overview of what we're going to cover in this lecture. I wanted to talk about infections that are common, that you probably frequently see in practice, but also that are things that you might get asked about on the boards that have not specifically been covered in the other lectures. So the first one I want to talk about is skin and soft tissue infections. And within that topic, we're going to talk about abscesses and cellulitis, which are distinct entities. And then we're going to move on and talk about urinary tract infection and asymptomatic bacteriuria. And then lastly, I want to cover spend some time on influenza therapy. So first, let's talk about skin and soft tissue infection. An estimated 6.3 million physician office visits and about 870,000 admissions per year are due to skin and soft tissue infection. Skin and soft tissue infection, though, is a really broad term that actually covers a couple of distinct types of infection. So this includes cellulitis and also purulent skin infections or abscesses, which are often lumped together. This includes with ICD-9 code, or excuse me, ICD-10 codes. But the microbiologic causes and management of these two different things are different. So just to sort of make sure we have our definitions straight, an abscess is a purulent collection in the subcutaneous tissue or deeper dermis. It forms sort of a tender red nodule that's fluctuant. You can feel the purulence in there. And it often has a rim of erythema. In contrast, cellulitis is an infection involving the upper dermis, deeper dermis, and subcutaneous fat. It causes a tender, red, warm, rapidly spreading area on the skin, but it is not fluctuant. It occupies more real estate usually, so it's a bigger patch of an area of redness. So first, let's cover the purulent skin and soft tissue infections. So the microbiologic cause of purulent skin and soft tissue infections is readily determined because there's pus there, right? You can culture it. Predominantly, these are going to be due to Staph aureus, and that includes methicillin-sensitive Staph aureus and methicillin-resistant Staph aureus. Occasionally, you will find that these are polymicrobial depending upon the location. As we know, things like diabetic feet, if there's an abscess there associated with a foot wound, can be polymicrobial, for example. In the last 2 decades, visits to the emergency department for abscess have increased quite a bit. And this really is related to community-acquired MRSA and how it's affected people. So most purulent skin and soft tissue infections require incision and drainage. Historically, guidelines have recommended incision and drainage alone for mild abscess where there's no systemic symptoms present. And then they recommend incision and drainage with antibiotics for moderate or severe purulent skin and soft tissue infections. And that's certainly what you would find if you looked up the most recent guidelines from the Infectious Diseases Society of America from 2014. But since then, a couple of studies have come out that have changed our thinking on this. So the first one was in the New England Journal in 2016, and it was a study of trimethoprim sulfa versus placebo for 7 days in over 1,000 outpatients with newly drained abscess. The definition of abscess in this particular study, they had to be larger than 2 centimeters. But I'll remind you, a 2 centimeter abscess is actually pretty small. So these patients also had to be slated for outpatient care. So they had to have basically mild abscesses. So what they found is that the trimethoprim sulfa treated patients had significantly higher cure rates at 1 to 2 weeks after the antibiotic therapy ended. Again, raising the question of, should we be giving antibiotics to people with even small or mild abscesses? The second study on this topic came out in 2017 in the New England Journal, and it looked at trimethoprim sulfa versus clindamycin versus placebo for 10 days in about 780 outpatients with newly drained abscess. And in this particular scenario, they were trying to look at the smaller abscesses, and specifically, it included ones that were smaller than 2 centimeters. So anything less than 5 centimeters that was drainable could be enrolled in this study. Trimethoprim sulfa and clindamycin had a similar high cure rate 1 week after the antibiotics ended, and that was better than placebo. So the thing to know about these two studies is that both of them, at the centers where they were carried out, we found that MRSA accounted for approximately 45 to 50% of the abscesses. And so what I would say is that these studies really apply to places where you see MRSA with some frequency. We're not sure that, these data would be applicable if you work at a center where there's like literally no MRSA abscesses and you're just seeing methicillin-sensitive Staph aureus. So let's move on and talk about non-purulent skin and soft tissue infection, or cellulitis. So unlike the purulent infections, the microbial cause of cellulitis is often undefined. Blood cultures are positive in less than 5% of the episodes. So guidelines do not routinely recommend them that you check them for all uncomplicated cellulitises. Studies of punch biopsies, when you do a punch biopsy on an area of cellulitis, and also serologies collected in people with cellulitis, indicate that group A strep and other beta hemolytic streps, so group B, group C, and group G strep, are really going to be the most frequent cause of cellulitis. Occasionally, Staph aureus is present, but that's the minority of times, and usually that's when there's like a skin wound. So for example, you can see a Staph aureus cellulitis in somebody who had a recent skin biopsy or area of stitches. The redness that extends around the sutured line is typically due to staph, and you don't necessarily need to see pus in the wound, but it's the wound that sort of set up the cellulitis that then led to it being due to Staph aureus. Less common causes of cellulitis are typically exposure related. So the classic example that we think about for board exams is Vibrio vulnificus, which, as you may remember from med school, is a bug that likes brackish water. So if you live near the Chesapeake Bay and you hear about somebody who's been out clamming or some such thing, and they get a cellulitis, you think about Vibrio vulnificus. Another one of these is infections due to Aeromonas, which are typically fresh water. So what are the appropriate antibiotics for cellulitis? Beta-lactams that target strep, but also typically target methicillin-sensitive Staph aureus in case that's also present or unexpectedly there, are what we use. So that includes things like cephalexin and cefadroxil. Clindamycin is also a great option for people who are beta-lactam allergic, and it also treats both of those. Guidelines also recommend that you could use penicillin or amoxicillin, and that's certainly true if you feel confident that it's strep, which most of the time it is. There are certain patient scenarios in which you feel more convinced it's strep. For example, people with lymphedema after a lymphadenectomy, such as a breast cancer patient with lymphedema in their arm who shows up with cellulitis, that's almost always strep. And so sometimes people will feel more comfortable with those. But my practice is typically to use a cephalexin, cefadroxil, or clindamycin, some such antibiotic. So what about MRSA? Why haven't I told you we need to worry about MRSA? It turns out MRSA seldom causes non-purulent mild or moderate cellulitis. Two different pretty big studies have looked at cephalexin plus trimethoprim sulfa versus cephalexin plus placebo for the treatment of uncomplicated cellulitis. And both of them found no clear benefit of adding trimethoprim sulfa. The implication being that all of these cellulitis cases in these studies were not due to MRSA because they all got better with just plain old first-generation cephalosporins. Trimethoprim sulfa, I'll remind you, is not particularly active for strep. So you really have to be careful. If you have a non-purulent skin infection, it is not appropriate to give the person just trimethoprim sulfa saying, well, maybe it's methicillin-sensitive Staph aureus that would respond, but you wouldn't cover strep, which is really your most important thing, again, for an uncomplicated non-purulent cellulitis. So let's do a clinical case. This is a 47-year-old man with diet-controlled diabetes and obesity who presents to urgent care with one day of redness and tenderness of the right calf. He developed a low-grade fever to 100.1 Fahrenheit last night, a few hours after he sort of thought the redness was coming out. The redness spread up and around his leg since last night. He denies recent trauma to the leg, and he says, oh, it's happening again. And what he means is that this has actually happened to him 2 other times, this exact same scenario. And this is what his leg looks like. There's nothing else interesting on his physical exam. He is prescribed cefadroxil and will follow up with his primary care physician later this week. He asked for a work excuse and says he's worried about missing work for this again. This is becoming problematic since it's his third episode in about a year. So the question is, how can he prevent recurrent lower extremity cellulitis? A, prophylaxis with trimethoprim sulfa single strength by mouth daily. B, weight loss. C, start metformin to improve glucose control. D, prophylaxis with penicillin VK 250 milligrams by mouth twice a day. Or E, refer to podiatry for improved care of his feet. So go ahead and think about your answer, and then I'll discuss them in just a minute. So the best answer here is D, prophylaxis with penicillin VK. And we're going to talk about that on the next slide. But just to review the other answers, prophylaxis with trimethoprim sulfa is not the right answer because, as I just finished telling you, that drug does not really treat strep very well. And the most likely cause of his recurrent lower extremity cellulitis is strep. Weight loss, improved glucose control, and better care of the feet are all things that may help with recurrent cellulitis, but we don't have nearly as much evidence as we do with penicillin. So how do you prevent recurrent cellulitis? Recurrent cellulitis is common, but evidence to support preventative measures, like I just mentioned, are weaker. So indirect interventions like weight loss for obese patients, which this patient was, and improved care of eczema, or improved care of tinea pedis, specifically, athlete's foot, basically, may help. What we have better evidence for is oral penicillin, and that comes from this study where they looked at penicillin prophylaxis versus placebo for 12 months in 274 patients who'd had 2 or more episodes of lower extremity cellulitis. So what they found is that cellulitis occurred in 22% in the penicillin group and 37% in the placebo group. This demonstrates that people with recurrent cellulitis, it's a big problem. Even if you put them on prophylaxis, they still break through. But with these statistics, 22% versus 37%, the number needed to treat with prophylactic penicillin to prevent an episode of cellulitis is just 5. So that's a pretty good number. It means this intervention is pretty decent. There are certain predictors of failure. So if the person has had 3 or more episodes of cellulitis in the past, they may be more likely to fail. And if people have a pretty high BMI, so higher than 33%, they're more likely to fail. And then there was some suggestion that if they have pre-existing edema, they might be more likely to fail. The other thing to know about this study is that it very clearly showed that the effect of penicillin does not persist. So you don't get credit for time served. If you take your penicillin prophylaxis for a year and you don't have any episodes of cellulitis, that's great. But at week 1, after stopping the penicillin, you're going to be just as vulnerable to getting cellulitis as you were before you ever did the penicillin prophylaxis. So it's really only while you're taking it that you prevent the recurrences. And one last note, when you do penicillin prophylaxis and somebody gets a breakthrough episode, typically they will still respond to regular cellulitis therapy. So something like cephalexin, cefadroxil, clindamycin, dicloxacillin, any of those would probably still work. So let's move on and talk about UTI and asymptomatic bacteria. So uncomplicated urinary tract infection had some guidelines put out in 2011 by the Infectious Diseases Society of America, or IDSA. The recommendations were for otherwise healthy, non-pregnant women, and the large majority of infections in this scenario are due to E. coli, somewhere around 3/4 to 95%. These guidelines are like almost a decade old at this point, and new ones are in progress. So why am I talking about them? Well, these are really good guidelines because they have some really important themes. One of them is that there's been increasing resistance among typical UTI pathogens in the last 2 decades that we think about. And the other is that they really focus on this concept of ecological adverse events from antibiotics. What does that mean? That means that we manipulate people's fecal microbiota profile when we give them strong antibiotics for sort of simple UTIs. So this is part of what they call collateral damage. And this is what can lead to C. diff or, just dysbiosis. So these guidelines were really very mindful of trying to minimize that. So here's the basic table from the guidelines that I like to focus on. So basically they outline what they mean by uncomplicated UTI, and then they recommend one of 4 different therapies, and we'll go through these carefully. So they recommend nitrofurantoin for 5 days or trimethoprim sulfa for 3 days if you are in a scenario where E. coli resistance is less than 20% at your center, which you do need to be mindful of that, or fosfomycin, which is kind of a funny drug we'll talk more about on the next slide. It's given as a single dose. It's a packet that's mixed up. The 4th antibiotic they recommend is something called pivmecillinam. That is not available in the US, so that's why I have a blue box over it, because we don't have access to that drug here. What they don't recommend are fluoroquinolones. And I'll just remind you, in 2016, the FDA came out with pretty hefty warnings about fluoroquinolones and neuropsychiatric effects. Since then, we've learned that fluoroquinolones can also increase your risk for aneurysms. So fluoroquinolones for a really simple, uncomplicated infection, bad idea. Beta-lactams also are not so great. They mess with your flora a lot more, etc. So let's think more about fosfomycin and nitrofurantoin, because those are really top choices here. Why do we like those, and how do they compare? So let's just go through this step by step. The mechanism of them. So the mechanism of fosfomycin is that it inhibits the bacterial cell wall synthesis. It turns out it does have a relatively low barrier to developing resistance with certain bugs. So how does nitrofurantoin work? It's a weird drug that has an interesting mechanism. The drug itself is actually activated by bacterial flavoproteins. It causes these unstable radicals of nitrofurantoin that are active sort of intermediates, and these are what interfere with bacterial DNA and RNA synthesis. So it acts on sort of many levels, and this is why people think that nitrofurantoin is not that easy to become resistant to. So what about the pharmacology? Both drugs are well absorbed. Fosfomycin is excreted unchanged in the urine with very high urinary concentrations. Oral fosfomycin is only approved to treat urinary tract infection due to E. coli and Enterococcus faecalis. And that's because it really doesn't effectively treat things in other places when given orally, because it basically ends up all in your urine. So nitrofurantoin, when you take it orally, it's distributed to most body fluids. It's just that it's very rapidly excreted in the urine and then the bile in very high concentrations. So just like fosfomycin, this drug, when taken orally, ends up mostly in your urine. So it's great to kill bugs in the urine, and it really doesn't seem to affect bacteria in other places very much. So this is why both have low impact on your GI flora. So the ecology of these drugs is good for not messing with people otherwise. So how do they compare performance-wise? In a recent clinical trial of a single dose of fosfomycin versus 5 days of nitrofurantoin in 513 non-pregnant women with UTI symptoms, the patients treated with nitrofurantoin more often achieved clinical cure at 28 days after their first symptoms, so 70% versus 58%. So there is a hint that nitrofurantoin performs better. And this study was done more recently than the guidelines, importantly. And also, I think that in the last decade or so, because of the guidelines possibly, more fosfomycin is being used. And as I mentioned, it's easier for sort of circulating flora to become resistant to fosfomycin. So there are issues with fosfomycin resistance more than with nitrofurantoin. The last thing to think about with these drugs is the formulation and the cost. So fosfomycin comes as this packet of granules that you mix with water, and you just take it, you mix it with water, take it down, and you're done. So one time. But to do that, you have to pay $98 if you don't have insurance. So a single dose of fosfomycin, not that cheap if you don't have insurance coverage, which I will tell you, it's not always covered. In contrast, nitrofurantoin is supplied as capsules. You have to take it twice a day for 5 days, but it's really cheap. So $10 for a 5-day supply without insurance. So super inexpensive. Okay, So let's go to a clinical case. This is an 88-year-old woman with osteopenia, hypertension, and GERD, and she comes to the emergency room from her assisted living facility with right wrist swelling. She reports that she slipped on some damp leaves and fell on her hand earlier in the day while she was on her regular 2-mile walk around the neighborhood. She's a fairly spunky 88-year-old. Other than wrist pain and swelling, she denies other symptoms, including fevers, chills, cough, nausea, diarrhea, or dysuria. Her labs are at baseline. Urinalysis shows trace leukocyte esterase and nitrates. An X-ray of the right forearm demonstrates a fracture of the right distal radius. In addition to consulting orthopedics regarding her fracture, the next best step is A, treat with nitrofurantoin for UTI, which is indicated by the leukocytes in her urine. B, treat with ciprofloxacin for UTI indicated by nitrates in her urine. C, since she has no UTI symptoms, no further workup is indicated. Or D, send the urine for reflex culture since occult UTI may have been the cause of her fall. So think about your best answer. So the best answer is C, since she has no UTI symptoms, no further workup is indicated. And this will run through the guidelines on this. So just review the first ones. The first one, the leukocytes in her urine don't necessarily mean she has a UTI in the absence of symptoms, but nitrofurantoin otherwise is not a terrible choice, as we just talked about. Ciprofloxacin, really bad choice in the elderly with UTI that's uncomplicated. So even if she did have symptoms, we wouldn't choose Cipro because of the side effect toxicity profile and the FDA warning. And then lastly, I don't think we need to send a urine culture because again, she doesn't have UTI symptoms. So let's leave it well enough alone. So asymptomatic bacteria, the definition is the presence of one or more species of bacteria growing in the urine at specified quantity counts, irrespective of the presence of pyuria, in the absence of signs or symptoms attributable to urinary tract infection. New guidelines that came out in 2019 help clarify in whom urine culture should be checked in the absence of symptoms and who should be treated. Positive urine cultures often lead to treatment regardless of symptoms, but these guidelines point out that should not necessarily be the case. Why should we care about judicious treatment of asymptomatic bacteria? We should care because antimicrobial stewardship is important. We want to make sure we're only using antibiotics when we need them so that we don't breed resistance. That it also allows us to avoid antibiotic toxicities, which I've now mentioned 15 times. We want to avoid quinolones in this scenario. And then lastly, we get to avoid that collateral damage that the uncomplicated UTI guidelines mention, things like increasing our risk for C. diff. So this is a table that summarizes the recent guidelines about asymptomatic bacteria. So the first group they address are healthy, non-pregnant, pre- and postmenopausal women, and they recommend no screening or treatment when they're asymptomatic. While women with asymptomatic bacteria do develop symptoms more often, treating the asymptomatic bacteria has not been shown to improve their outcomes. What about functionally impaired community dwelling older men and women, like the woman we just talked about? No screening or treatment is recommended. And in fact, the guidelines specifically say if patients like this develop delirium or fall in the absence of GU symptoms, like our patient, you should look for other sources, other causes of those issues. What about long-term care facility dwelling older men and women? In that patient population, they recommend no screening or treatment in the absence of symptoms. So while asymptomatic bacteria is linked to antibiotic treatment, there's no reduction in mortality or change in mental status or admissions for UTIs if you treat asymptomatic bacteria. The other problem is drug resistance in this patient population. What about diabetics? Again, no screening or treatment recommended if they have no symptoms. Spinal cord injury or patients with impaired voiding, these are sort of the most challenging, I think, on these guidelines. So they say you should not screen or treat in the absence of symptoms, but they have an important caveat that I really take to heart in my practice, which is that the clinical signs and symptoms of UTI can be atypical in this population. So it can be a vague sort of pelvic pain, for example, in somebody with a spinal cord injury. So you have to be really careful with this patient population. And then lastly, what about patients with indwelling urethral catheters? They say no screening or treatment in patients without symptoms. So symptoms are things typically like fevers. Short-term catheter patients will have 3 to 5% bacteria that develop per day that the catheter is in. And then patients with long-term catheters, so people with, a suprapubic catheter for years, 100% will have a positive urine culture if you check it, but that doesn't necessarily mean that they have a UTI. So again, you got to go based on symptoms. So who should get screened and treated if they have asymptomatic bacteria? Pregnant women, so 2 to 7% will have asymptomatic bacteria. And this is based on studies from the 60s and 70s that showed you can reduce the risk for pyelonephritis in this population, which probably reduces their risk for preterm labor because you're reducing their risk for a serious infection. The IDSA suggests a urine culture early in pregnancy. And then patients undergoing urological surgery with high risk of breaching mucosal surfaces. So this specifically means people who are undergoing transurethral resection of their prostate or bladder tissue or a ureteroscopy. This does not include people getting a diagnostic cystoscopy or a ureteral stent removed. The reason why we need to screen and treat these people is because they basically have a contaminated surgical field. So they're at increased risk for symptomatic UTI postoperatively, and they also have an increased risk of bacteremia. So let's move on to my last topic, influenza therapy. And we're going to start with a case. This is a 57-year-old woman with RA on adalimumab and low-dose prednisone who presents to the emergency room with 72 hours of cough, body aches, malaise, and anorexia. Her highest recorded temperature is 100.8, but she feels chilled. She has a mild sore throat, but no nasal congestion. She has not been eating or drinking much for 3 days. Her vital signs are notable for a low-grade fever and a heart rate of 130. Her exam is notable for dry mucous membranes and a clear chest. She has a nasopharyngeal swab that's positive for flu A and negative for COVID-19 or other respiratory viruses. Her chest x-ray is clear. She's admitted to observation. In addition to giving her IV fluids, the best therapeutic plan is A, treat with a 5-day course of oseltamivir, B, treat with a 10-day course of inhaled zanamivir, C, symptoms have been present for more than 48 hours, so give her supportive care, D, treat with a 3-day course of oral baloxavir, or E, treat with a 7-day course of romantadine. So think about the best answer here. So the best answer is A, treat with a 5-day course of oseltamivir, which we'll get into the details of this more. Zanamivir for 5 days would also be appropriate. She's not somebody where you necessarily think they need this extended 10-day course for which there's limited evidence. She is somebody who merits treatment, which we'll get into in a minute. Baloxavir we'll also talk about. That's a new drug, and the treatment course for baloxavir is a single dose. So a 1-day treatment. And then romantadine and the adamantanes in general are no longer recommended for the treatment of flu, which we'll talk about. So what is standard flu treatment? Neuraminidase inhibitors are really the mainstay of therapy. They're active against influenza A and B. The mechanism is that they inhibit the virion release from infected cells, which you can see in this nice picture here. So basically, the virus buds off after it's replicated. And when it buds off from the cell, there are certain markers on the area where it's budding. And these include hemagglutinin. And the hemagglutinin, when it buds off, is bound to sialic acid on the cell surface. So the way that it sort of eventually releases is that you have to have a neuraminidase, which is going to cleave the hemagglutinin on the virus particle from the sialic acid. So if you block that process, then the virus cannot be released and it cannot go on to infect other cells. This is why you want to get this drug there as fast as you can to avoid infecting other cells. So it works better the sooner you give it. What about the adamantanes? What's the deal with those? Those are active only against influenza A. And the mechanism of these is that it blocks this thing called the M2 ion channel. So if this virus particle is released and it goes on to infect another cell, it basically is endocytosed. And in order to get out of that endosome, it has to have a protein in there called the M2 ion channel that allows acidification of the endosome. But if you block that, then the virus can never get out of the endosome inside the cell, so it can't really invade the cell. It sounds like a great mechanism. Unfortunately, though, it's no longer recommended because influenza A resistance over the last decade has really taken off. The only time in the last 12 years or so that we used this drug was in 2008, 2009 H1N1 flu, and that was the pre-pandemic flu. So this was an old circulating strain of H1N1 where it worked, but it hasn't really worked that well since, so we don't use it. So let's talk a little more about neuraminidase inhibitors. Most studies conducted were in low-risk patients with uncomplicated flu, and basically it causes a shorter duration of symptoms by about 24 hours. It's harder to study the high-risk population like the patient I told you about in the case. And it's hard to prove other endpoints like reduction in hospitalization or lower respiratory tract complications. This is a table that just shows you the neuraminidase inhibitors that are available. So oseltamivir is available as pills, which we talked about. You can also get it in liquid for children or people who can't swallow pills. Zanamivir is a drug that in the US is only available in an inhaled form that has similar effect to oseltamivir. And then I'll just remind you, there's this third neuraminidase inhibitor called peramivir. It's approved for the treatment of uncomplicated flu with a single IV dose. Sometimes this drug also gets used in people who are critically ill with influenza, where they can't reliably take pills. And in that scenario, it's typically used as a daily IV infusion, but that is not how it's FDA approved. So who should be treated? This is taken from the recent influenza guidelines. Clinicians should start antiviral treatment as soon as possible for adults and children with documented or suspected flu, irrespective of their vaccination history if they are hospitalized, regardless of how long they've been sick, or if they have severe or progressive illness. Also, patients who are at high risk of complications, like our case patients, including those with chronic medical conditions and immunocompromised, like our patient. You should also treat children younger than 2 and adults over 65, and pregnant women up to 2 weeks postpartum. So the people that you don't have to treat, but you can consider it, is outpatients with symptoms for fewer than 2 days, or symptomatic healthcare workers who live or have frequent occupational contact with very vulnerable patients. So for example, an oncologist who comes down with the flu would be somebody in whom you would consider treating, since they've had frequent contact with vulnerable patients. So the last thing I want to cover is baloxavir, which is this new drug. It targets the viral RNA polymerase complex. It's active against influenza A and B. Initial human studies in healthy people showed that it's safe and has a very long half-life of 2 to 4 days. So that's why you only give a single dose of this drug. It's FDA approved as 40 milligrams by mouth once for uncomplicated flu in patients with fewer than 48 hours of symptoms. So the approval was based on phase 2 and phase 3 studies in adults with uncomplicated flu or flu-like illness in Japan and the US. Baloxavir shortened flu symptoms by about 24 hours compared to placebo, and it was very similar in terms of performance to 5 days of oseltamivir. The adverse events were similar between placebo, oseltamivir, and baloxavir. The important thing to know about this drug is that in this phase 2, phase 3 study from the New England Journal in 2018, among those who were tested for flu after they'd completed their baloxavir treatment, about 10% had evidence of resistance to baloxavir. So this drug seems to have a low barrier to resistance. And for this reason, it's currently being studied in combination with oseltamivir for critically ill influenza patients to understand if one really good role for it would be in combination for very, very sick patients. Time will tell if that's how we use it. And with that, I'm concluding my lecture here. Selected references if you'd like to do any further reading on the topics that I talked about. And I thank you for your attention.